I'm Dr. Ramesh Adiraju from Philadelphia. I'll go over a few important aspects of intervening for peripheral vascular disease, particularly distal SFA, popliteal and below-knee, with some case examples. Complex peripheral vascular disease, the two aspects to remember is the extent of thrombus in these lesions is significant and has to be very carefully managed, and this is what non-management of optimal or optimal management of thrombus is what prevents complications during these procedures and also restenosis and long-term patency, especially in SFA disease. Here's a case example of a 72-year-old male, wheelchair bound with severe peripheral vascular disease, who presents with rest claudication. So even though he's not ambulatory, he's on the verge of critical limb loss. Multiple risk factors, standard ones. ABIs were 0.54 on the right side and 0.33. He presented with cold foot, and on the angiography. Why is the video not playing? Oh, okay.
Just click on this.
Here's an angiogram. As you see, it's diffusely diseased SFA, calcified multiple sequential lesions of the distal SFA. Popliteal is also involved. And there's significant below-knee disease. No. There's a little bit of a delay in video clips. As you can see, infrapopliteal hardly anything, and there's one single tibioperoneal runoff which hooks into a collateral vessel. One aspect of below knee, these are small vessels, diffusely diseased, particularly diabetics. Important thing to remember is stenting and ballooning in peripheral vascular disease is extensively done across the board. These are not like coronary arteries. I believe peripheral vascular disease should be managed with the debulking as much as possible and also manage the thrombus. This is a case example to demonstrate that. Here is Silverhawk atherectomy of the distal SFA and popliteal using a mid-size cutting device. As you can see, you can cut around the calcium. The key in atherectomy for peripheral vascular optimal atherectomy is to adopt this, what I call a differential cutting technique, where if you can pass the device across the calcium, there's usually, it's almost never circumferential calcium. There's usually one segment in the circumference that has a soft part. You cut around there and then cut under the calcium. In this way you can obtain optimal atherectomy. There you go. This is after the multiple passes. As you can see, nice lumen establishment. You really don't need to stent these. This is more demonstration of slow pass differential cutting technique. Slow pass is also an important aspect. It prevents distal embolization and also obtains optimal atherectomy. As you can see, the shaft of the Silverhawk, the second generation Silverhawks, has a bend to it so it can hug the plaque and get more optimal atherectomy, which can be used to the advantage if you adopt the slow passing technique. But it can be dangerous if you aggressively push the device. The same bend can actually cause dissections. So it's a slow pass differential cutting technique is a key to obtain optimal atherectomy. Sorry, here the mouse is not working that well. There's kind of some temporal delay from one slide to the other. So this is after multiple passes achieving optimal atherectomy. Then there's popliteal disease. Again, stenting or ballooning in distal SFA and below, I believe, is a waste of time in peripheral vascular disease. If you can't atherectomize and debulk them, you should just bypass them. There are alternate modalities that we use at our institute, which is end-diastolic compression treatments that improve neorevascularization, which is better approach. Here's after the popliteal first pass. Silverhawk of the popliteal. There's a lot of delay from one side to the other to mark. Okay. Popliteal looks, that's after primary atherectomy, no ballooning. Is distal disease now, which we need to tackle. As you can see, the runoff is still very poor, and he came with a cold foot. Then we wired it's a long total occlusion that hooks up with a collateral. Wired the collateral, you can park your wire in the collateral and have some room to pass the Silverhawk. This is Silverhawk below knee. As you can see now, the collateral opens up and you have a good one vessel runoff. That's the final angio. In this case, it was done in 2010. This gentleman still has good distal runoff and doing well and saved his limb 2.5 years out. Here's another case, an example that I want to show the up and around access is something that I always like to do because Silverhawk atherectomy, the device needs a little proximal support. So I don't go retrograde approach, it's always up and around. Up and around is a difficult access, most people shy away from, especially in sharp angles. This is something like a mother and child technique that we use for peripheral vascular disease. You get the long sheath across up to the bifurcation, get a glide wire across with a diagnostic JR catheter through the sheath, and then actually you can see in the picture, I drag the diagnostic catheter and the sheath will slide right around it. That's a way to come up and around. It always works no matter how much angulation there is. It's a demonstration of that technique, which is a useful one. It's called the catheter tunnel technique. Next slide. Here's the right side. As you can see, it's another critical disease, total occlusion that hooks up with the collateral. You always try to wire the main vessel if you can get the wire across. Here is a demonstration of a knuckle wire technique. I use a regular balloon with a bend on the wire, and with daughtering with the balloon and a knuckle wire technique, you can most of the time get across peripheral lesions, especially long total occlusions. Like I said, that clearly demonstrates that these patients have significant thrombus burden on top of the lesion, and if you really work at it, you can get regular coronary wires across. Next. And then proceed with Silverhawk. This is now across the long total occlusion. Next. I put this part to just demonstrate, after you revascularize a total occlusion, you can see the staining you see all around, that's the venous stasis. Venous aspect of peripheral arterial disease is something people don't consider or even think about. If there is chronic venous insufficiency, especially in long total occlusions and diabetics, these patients have increased restenosis because the venous system in lower extremities has to work as an active pump. It pumps against gravity. So if there is venous insufficiency, it becomes a bottleneck phenomenon for the arterial system, which is what increases restenosis and delayed lack of patency after SFA and Belloni disease. We circumvent this by using end-diastolic compression treatments after arterial revascularization, and the restenosis rate is much less with that. I just wanted to show this case to demonstrate what I mean by the venous insufficiency in these patients. This is another reason that ballooning and stenting of mid to distal SFA and Belloni should not be done, because the venous system runs parallel to the arterial system, and if you are ballooning and stenting these vessels, it crushes the venous system and creates a chronic venous insufficiency, which is what predisposes to repeated arterial occlusions. Next slide. Here's the final angiographic result. Has a good one vessel runoff. Key is to establish one good vessel runoff, and it can build up collaterals and maintain circulation for future. There was some distal disease. Again, tendency after you got a total occlusion open is to go balloon that, which I recommend not to do that. If there is distal disease, go back in and debulk it. Here's the final angio. Nice dark filling. Even the branches are filling, which means it will develop good collaterals to the other vessels. For lack of time, I think I'm going to stop with this case. This is the third case. If we have time, we'll show. Do you want me to go ahead and show the case?
We have, I think we are already probably late
so
5 minutes.
This is another interesting case that brings home a lot of points that I mentioned about peripheral arterial intervention. It's a 62-year-old male who presented with gangrene of the left heel. He's a diabetic post-CVA, severe diabetic vasculitis, it's diffuse atherosclerosis. He's status post Belloni amputation and has a left to right fem-fem graft that was placed in 3 years ago. There was no, because of the fact that he has occluded iliac vessels, he had no access from the groin, and also the ischemic foot that he presented with was left, and he has a fem-fem graft which will be very difficult to go up and around. So we went brachial access to this patient and did a angiogram. As you can see, it's complex Next. He has totally occluded right common iliac. Next. As you saw, there were two lesions, one proximal and one distal, to the fem-fem graft. And then there was distal disease, which is, if you have to balloon or stent this, you would either lose the fem-fem graft or in the joint area, there's high risk for stent fractures and thrombosis. So then we went down, put a long sheet, and did primary Silverhawk atherectomy. There was one question people have when I talk about atherectomy, peripheral vascular disease using Silverhawk, is how far can the device reach? As you can see, the technique I used here, it reached the proximal lesion just about. And then for the distal lesion, I used, as we Silverhawked, we actually advanced the sheath. So you get better length on it. So you can do a couple different things. Sheath advance technique that I was talking about, right there. As you can see, the sheath moves with the device. Here's a follow-up angiogram, and there is still 30–40% residual. Again, you should resist the temptation after you've done the first or 2–3 passes to just balloon or stent it at this point. That's the wrong thing to do for peripheral vascular disease, because you create dissections, you create distal embolization, and you create restenotic milieu for the future. So I strongly suggest, and I do this passionately, go for optimal atherectomy. This is a case to demonstrate that. Because of residual more than 30–40% stenosis, we continue to do second pass, third pass, still some residual. So went with the fourth pass. And then Silverhawk, this is another thing. How would you identify, selective cutting? For example, if you have an inferior residual plaque left, is it a high risk to just try to go get that and then you risk dissection or perforation? Silverhawk has a window that's very clearly visible fluoroscopically as like a little tray, and you can direct that. The technique, since it's a monorail bent system, is to do a quarter turn and just see how much it turns, let it take the turn, and slowly but steadily you can selectively go after residual plaque just to the plaque. And that's the technique to avoid dissections and perforation. There was still some disease, and that's the final result of the atherectomy. As you can see, the distal one is completely open. Now he's got flow both sides through the fem-fem graft, and there is distal flow established, as you can see. Let it run through to the foot. And the heel, gangrene actually healed naturally, scuffed off without any secondary infection, and the guy was discharged home. I'll stop here.
Sure.
Take any questions.
Is that you recommend that when you use Silverhawk, you should not use a balloon, but if you do dissect, do you have to put a stent? Obviously.
If you do dissect, if there is non-flow, if there is no flow limitation, and if the dissection is minimal,
you should still leave it.
You should still leave it. I would very strongly recommend not to stent peripheral vascular disease.
One more question I have, that when you have, so for example, multiple tendon lesions in the SFA right down to popliteal, and below the popliteal you showed one case, both the vessels are occluded. What criteria you use that you have done a good job? How would the perfusion, would you have an angiographic assessment? Or?
Yeah, immediately as you can see, it should be a TIMI 2 or 3 flow established at least one vessel runoff into the foot. That's a good landmark to hang your hat on. Because if you have one good vessel runoff, the other vessels will
So do
get
you recommend that
collateralized.
Silver Hawk is a very decent device to treat multiple diffuse atherosclerotic disease of lower limbs?
Yes. So,
And
primary atherectomy combined with thrombus management as much as possible. If we have time, I'll show another case where significant, at least 50-60% of what you see in these total occlusions is thrombus. Sometimes after crossing the lesion, I do thrombectomy first, which actually prevents distal embolization, gives you a channel of recanalization to use Silver Hawk optimally, and prevents, you can assess the vessel properly and avoid dissections and perforations. So thrombectomy, atherectomy as a primary approach, especially for SFA, if you can't achieve that, it's better to bypass them. But distal disease, of course, is try to establish one vessel runoff and they do well.
Thank you, Dr. Patari.